We're glad that you've joined us today. I appreciate that this is valuable time in your week. And I hope that as we talk together and share some interesting cases, that you will find it rewarding. I always enjoy looking at interesting slides. And so I hope that as we discuss these cases today, that you'll find them helpful. Also, that you'll feel free to ask questions as we go along. If you don't want to speak up and unmute yourself, you certainly can type your questions into the chat. And then we will deal with them when I notice them, either at the time or towards the end of the session today. I have about 9 or 10 cases that I have come across again recently. The backdrop here, of course, is that I have a few gray hairs and I realize that I'm not going to be around forever. So I've been culling through my collection of glass slides for the last 30 or 40 years to pull aside some of the best ones and to get them digitized so that they can be a lasting benefit. So the first of these is one that came from my early years in practice. I think a 18-year-old patient who had a lytic lesion in the bone, I believe his femur. And this lesion appeared to cross the growth plate. So it was a metaepiphyseal lesion. And of course, in a 19-year-old metaepiphyseal lesion, is going to have a fairly limited differential diagnosis. You're going to be thinking about things like giant cell tumor. You're going to be thinking about maybe a chondromyxoid fibroma, maybe a chondroblastoma, although usually those don't cross the growth plate. And then also possibly, obviously, an osteosarcoma comes into that differential as well. So the orthopedic surgeon did some curettings, which you can see here. And now a couple of things that you notice at low magnification, of course, is that you've got some hypocellular areas and then some very high cellular areas. And we've got a couple of these sorts of areas, which could be necrosis or a second tissue type. And then we've got a few areas of hemorrhage. And probably also at this magnification, you should be able to begin to appreciate that there are some giant cells here. You can see these slightly condensed areas here as well. And I emphasize this because your low magnification view, your first view of something, is going to be very helpful in terms of your ultimate diagnosis. So we'll take a look at some of these high cellular areas. And indeed, you see as we come into magnification that we do have multinucleate giant cells in the mix here, as we do with many bone lesions, of course. And then we have some stromal cells or other cells surrounding it, which have fairly large nuclei, but a moderate amount of cytoplasm as well. We may have some hemosiderin deposition here in areas, and then we see the giant cells. Now, the giant cells are sort of osteoclast type giant cells. The nuclei are not arranged in a circle per se. They look fairly similar, the nuclei, to the surrounding stromal cells, which is a feature that sometimes we would look at traditionally to characterize giant cell tumor of bone. Well, let's take a look at some of the other tissue types that are here. Here we see a little bit lower cellularity area here, maybe a little bit more fibrous tissue here. So a little bit of an alteration in the cellularity there. Over here, we may see what could be the beginnings of a cystic component. As you know, sometimes aneurysmal bone cysts can occur in this location, either as a primary lesion or as a secondary lesion related to underlying giant cell tumor or other lesion. So we may have that sort of a component going on based on that cystic tissue there. And then we'll come back and look at this other tissue here we highlighted at the beginning. This sort of rounded area is a little bit unusual. And as we look at this, in fact, we see that this looks more like cartilage tissue. Um, you've got sort of low cellularity cells with lacunae. It's not quite classic hyaline cartilage, but it certainly could be a little bit of a remnant of the endochondral growth plate that this tumor has traversed and that has been caught up in the curettage. So in terms of mitotic activity, we don't see a lot of mitotic activity. We don't see a high degree of anaplasia that would suggest osteosarcoma. Of course, I'm showing you this without the benefit of the radiograph. And this was done at a time prior to having really much of anything in terms of immunohistochemistry available to us as workup. However, we did still come to the conclusion that this represented a giant cell tumor of bone. It did not have the myxoid or cartilaginous features of a chondromyxoid fibroma. It certainly did not have any of the chicken wiring that we would see with chondroblastoma. And my screen has frozen here for a moment. Let's see what we can do about that. Oh, there we go. Reload the slide. That may help. So we came to the conclusion that this was indeed a giant cell tumor of bone. The patient had a curettage and did fairly well postoperatively. And as far as I know, did not have a recurrence. So that was fortuitous. All right, so let's go on to the next. Actually, this is not the next case. Let's go back here. We're going back. Let's go on here to the next case. And this is a large soft tissue mass that was present in the deep tissues of a proximal extremity. I believe this was around the shoulder girdle. And you can see this was an adult patient. Now, I apologize for the scanning lines. We're still using the scanner that we first obtained in 2008. And so the scan fidelity has deteriorated a little bit in that. But we can still capture the image and sort of subtract out those scan lines. As you see, this is a sort of quasi-lobulated tissue with a lot of intercellular edema or myxoid change, perhaps. And it's fairly cellular. It doesn't look like any normal tissue that we would be inclined to encounter. And we see that we've got some pleomorphism here. We've got big bizarre cells. And if we were able to go to a really high magnification, I think you'd see that there are mitotic figures, some of which are atypical. Now, as I went through these cases, one of the interesting things in looking at these old cases from my teaching files was to recognize how nomenclature has changed over time. So this went into my teaching files as an example of inflammatory malignant fibrous histiocytoma. Well, you can go searching WHO categories now, and you won't find that term used with any of the modern tissues. Let's see if we can do this again. We're having a little trouble technically. Oh, you know what? I think it's going to make me sign in. So let me just see if I can't take care of that and go back here to my presentation page, and I will log out and log back in, which should accept my credentials and allow us to resume the review of these cases. So as you may have noticed, these cases are lodged in my Digital Pathology Association or Digital Anatomic Pathology Academy account, which has a number of great benefits. It's not very expensive if you're in the West, and if you're from a low or limited resource country, you can actually get a complimentary membership, which includes access to DAPA. And that really pretty much allows you to store an unlimited amount of your own digital slides and to use them for teaching, also to access all of the resources within DAPA that include presentations like this and a wonderful library of reference cases that have been curated and evaluated by really leading experts in their fields. So, as I mentioned, you won't find the term myxoid, MFH, anywhere in the WHO categorizations these days. And I believe this tissue, this sample here issely fits into what is today called Myxofibrosarcoma. And that is a tissue lesion which has a very high cellularity, high degree of pleomorphism. It's a high-grade sarcoma, and it has this myxoid change with a degree of lobularity and the kind of pleomorphism and atypia that we have seen in this sample. So that's another, just a nice example of that entity to store in your brain for the next time you see a needle biopsy on this lesion. Obviously, these lesions are treated with fairly dramatic surgery if they're resectable to get good margins, and then they may follow along with some additional therapy. Okay, well, our next case, I will admit that this is a little bit of a how would you say, almost a unicorn type of case. It's very unlikely that you're going to see one of these cases in your experience. But this was an adult patient who had somewhat symmetrical changes in his long bones that seemed to indicate there was some sort of a replacement process. Now, this might show up today as possibly an alteration on the bone scan, or possibly even a little bit of diffuse PET avidity if they were doing a PET scan. As you can see here, we have a sample of essentially fatty marrow, but rather than finding in between the fat cells a normal hematopoietic component, we're instead seeing a lot of pink cytoplasm here. And as we come into very high magnification, I believe you can see that there's a kind of a foaminess or pallor to the cytoplasm with some degree of granularity and interspersed hypo staining material in these cells. So it looks like a very histiocytic type of process. It is not associated with any significant acute inflammatory process. So what is our differential for something like this? Well, if this were an isolated lesion, we certainly might entertain the possibility of something like a Langerhans histiocytosis, but that would not be a diffuse involvement kind of process, which is what was suggested here clinically. Additionally, with Langerhans histiocytosis, we might expect to see more eosinophils. I mean, it isn't called eosinophilic granuloma for nothing. We might consider various infectious processes, things like Whipple's disease or other granulomatous type of infectious or inflammatory processes. This is not really forming any sort of true granulomatous process. Notice it's interspersed between the the fat cells, but it's not really indenting them or displacing them in a mass lesion type of process as you might expect with a granulomatous experience. What else might we consider? Well, we might consider some of the storage diseases that can also give you this type of a histiocytoid process. I'm sorry, that area is not in good focus. Here's a little better area here. And in fact, as we delved a little bit further into the patient's history, indeed, that's what we discovered, that this patient did have a storage disease, which was characterized as as Gaucher's disease. So Gaucher's disease is a genetic disorder that's inherited, and you're missing one of the key enzymatic links in the metabolism of various lipids. And so you begin to accumulate these lipid-laden macrophages within the interstitium. Now, usually this accumulation is most prominent in other areas of the reticuloendothelial cells, such as the liver and the spleen. But bone marrow can also be involved. Now, if you are doing an aspirate on these things, these will give you a nice aspirate, and it's characteristically described that these cells have what's described as a cigarette paper-like appearance to the cytoplasm. And by that, I mean, most people now are not rolling their own cigarettes, but it's a very fine lattice type of an appearance to the cytoplasm on the aspirate cells. So this is truly a one-of-a-kind case. We don't see this on routine bone marrow examination in most cases, but it is good to know that this is one of those things that comes into the differential diagnosis of various histiocytoid infiltrates that can be seen either in the bone or in other areas of the body. Okay, so that's the unicorn case. We'll go on to the next case here. This is an abdominal mass. Oh, something happened here. Let's come back to... if we can find what happened. It looks like my whole browser crashed. I apologize for that. Fortunately, we can get back there fairly quickly. So here's the this is the dial or the navigation page for DAPA. And we'll go forward here. Okay, so here we are on case 4, and we'll expand out the screen here so you don't have to look at everything else. So this is an intra-abdominal mass in a 65-year-old patient. And I think this case, a fairly recent case, taught me a number of lessons. First off, we see it's a high cellularity mass. It's not a sort of a carcinoma type of organoid glandular structures or solid sheets of tumor. We have mostly kind of single cells in a sort of hyaline background. And there's a degree of pleomorphism to these cells. Almost wondered if it could be a hepatocellular carcinoma, high grade, or something of that sort, with this very sort of single cell and fibrous fibrocollagenous matrix in the background.
Slide is not visible.
I'm sorry?
Slide is not visible.
Oh, sorry. Okay, let me come back here. I have to do the reshare, of course. So thank you for catching me. Okay, that should be better. Over here, just check.
Yes.
Okay. Thank you very much for catching me on that. So we'll come back to low magnification here again, let you see how this tumor is laid out. We've got some vasculature, a lot of high cellularity, some low cellularity areas, no specific structure to the tissues other than this sort of single cell, somewhat infiltrative pattern with intervening vasculature and fibrous tissue. It looks a little bit like liver, but we don't have any normal, bile ducts or anything like that to indicate that that's where we were. And clinically, this was just listed as an abdominal mass. So approaching a very high-grade pleomorphic tumor like this can be very daunting. And thank goodness today we have a variety of tools to use. So this was approached first with immunohistochemistry. And that was, things we thought about would be, undifferentiated carcinomas, hepatocellular carcinoma, maybe melanoma, certainly very pleomorphic for that even. And then some of the possible soft tissue tumors of varying types, epithelioid sarcomas, and various other sorts of things of that ilk. Although certainly for epithelioid sarcoma, presentation as an abdominal mass would be highly unusual without a more remarkable history of a peripheral lesion. So pretty much this was negative for all epithelial markers. It was negative for the hepatocytic markers. It was negative for any of the common things that we might think of. Melanocytic markers were negative and so forth. So that left us kind of thinking, well, this is some sort of a sarcoma. And in general, we don't think of highly pleomorphic sarcomas as being fusion gene driven. Usually the sarcomas that are most commonly driven by a kind of single fusion gene tend to have a kind of lower grade appearance, more monotonous, not this highly pleomorphic kind of polyploid kind of process. But my colleague, Dr. Fung, did do some molecular analysis, first looking for ESW gene rearrangements or multiple duplications, and then subjecting it to some further molecular analysis. And ultimately was able to demonstrate in this lesion DDIT3 FUS fusion gene partner with some unbalanced other mutations as well. But that would put this into the category of a myxoid liposarcoma. The DDIT3 FUS fusion gene is quite characteristic and diagnostic for that entity. So rather than being left with just kind of high-grade sarcoma, we were able to say, high-grade sarcoma with at least some backdrop in the myxoid liposarcoma category. Now, thinking back on my training years, I think there's no way under heaven that I would ever have looked at this case and thought, this looks like a myxoid liposarcoma. It just doesn't look like what I had imagined as a myxoid liposarcoma. And that's one of the things that is happening as we further refine our tools. Yes, there is, I think, a little bit of myxoid tissue here. And yes, these cells are somewhat rounded. So it certainly is conceivable now in looking at it that I might say, oh, there's some lipidized cells here. Maybe we should think about liposarcoma. And in fact, that's where we end up. But there's just the very smallest suggestion that this tumor has an adipocytic derived lesion. So I think that's the lesson that sometimes going to high magnification and looking for features like this or this in rare single cells can give you a few clues. And I don't know if my partner did that in evaluating this tumor, but I found that that was a very insightful or very instructive feature to learn from this case, to look at some of the single cells, to look for some of those subtle clues like very gentle vacuolization, as we see in a few fields here. Okay, well, we'll go on to another bone case. I was going through most of the bone files in my teaching files, and that's why we've got a few extra bony cases. So this is I think, 25, 26-year-old patient who had a little bit of pain and then was found to have some abnormal distortion, almost as it were, of his tibia. And that led then to some concern that there might be a neoplasm. So here is what we see. We have this periosteal tissue out here. And this is, mind you, from the diaphysis of this bone, not the epiphysis or not the, not another part of the bone. We can see that the patient's still fairly young based on the degree of reorganization of their Haversian systems here. Actually, he may be younger than 23 based on this appearance. You can see here, we're still looking at primary lamellar bone, so he may actually be in his early teens. I may be misremembering the age. But what we see are a number of foci here in the subperiosteal tissues of a little thin cartilaginous cap. And beneath that, some hypervascular tissue and some sense that we have, as you can see here, endochondral type ossification. So these findings, a relatively normal periosteum, a cartilaginous tissue with endochondral ossification occurring away from the growth plate, leads us to the diagnosis of an osteochondroma. And in this particular case, the chondromatous tissue is still fairly flat and disseminated along this subperiosteum type of tissue. The pathogenesis for this lesion is thought to be essentially just displacement of some of the growth plate cartilage tissue that gets pulled along either in a localized manner as the bone grows. And then this tissue can continue to proliferate and produce bone without the same kind of growth controls that we usually see at an endochondral growth plate. Now, it's unusual for it to be in a long and flat distribution, as we see here in this pattern. This is really quite an uncommon distribution because usually it's fairly localized and it will tend to then grow perpendicular to the underlying bone, sort of grow outward. But in this case, it's sort of just very gently, very slightly thickening the cortical bone and producing a low level of growth. As these become polypoid or pedunculated and so forth, they become more easily diagnosed radiographically. This type of a lesion in a flat distribution with sort of just mild distortion of the bony architecture would be more difficult to diagnose radiographically. But typically, they have a normal marrow space connection to the underlying bone. And by removing this cartilaginous tissue, along with its associated bone, you essentially cause the lesion to heal over and no further problems are anticipated. In very rare instances, this cartilaginous tissue can devolve to develop neoplastic capabilities and actually become more chondrosarcomatous. But that's usually at a much later age and after a much more prolonged period of time of ongoing replication. So a rather unusual osteochondroma in a sort of sessile pattern growing along the surface of the lower extremity bone in this case. But I think it's good to review the anatomy of what's going on with these things, specifically to look for the evidence of endochondral ossification, which you can see here. Now, it may be that the reason that this underlying bone is not fully reorganized is that this is all bone that's been laid down by this cartilaginous growth plate, if you will, in the subperiosteum. And hence, this bone has not reorganized or remodeled itself yet to the same degree that the rest of the patient's axial skeleton might. But I do use that feature as a means of verifying, appropriate patient age and so forth, is looking for the degree of cellularity of the bony lamellae and how they're oriented and whether or not they've been remodeled. In this case, they're all the lamellar lines are parallel. There's no evidence of interruption and remodeling where they've been torn down and then re-laid down by new osteocytes. Okay, well, let's go a little bit further. This is a specimen that you will probably never see in your experience because the treatment for this particular disorder has evolved considerably since the time that this sample was retrieved. This is, again, a young child, I believe still in their preteen years. And here again, we can see that although here there has been some remodeling around these subversion systems, there's still a lot of primary bone. Now, you may be wondering kind of what the stain is here. And here you can see modeling lines here. And that probably is in part related to what's going on in the marrow space. So you see here then this marrow spaces, we have a very cellular tumor, very small cells and a scant amount of cytoplasm, kind of a small blue cell tumor. But it looks funny, doesn't it? Well, that's because this is a PAS stain, which is not something we typically do with bone samples. However, it can be very useful when you want to have, say you've got a lot of obscuring blood and you want to have the red cells kind of fall back out of the picture. The PAS stain does not highlight any red cells, and so they will essentially be invisible to you, whereas you will be able to see a little bit more of the underlying structure and get, of course, an idea for some nuclear features. Now, the reason we did a PAS stain in this situation is that in non-decalcified samples, Ewing's tumor tends to have a nice amount of glycogen, and so the glycogen will be highlighted. This obviously, however, is a decalcified specimen, and so all of that glycogen has been lysed or broken down, and even in these more thickly sectioned areas, you don't see too much evidence of that tissue here, or that cytoplasmic content. The teaching point here, however, is to see the pattern of growth of this tumor. This is one of those classic tumors that has a very moth-eaten pattern of bone destruction. It just grows so rapidly between the bony lamellae. It can begin to raise the periosteum, as you see it's done here. And here you see these beginning elevation marks of the periosteum. So the tumor is, as you see here, expanding the periosteum and causing the bone to be somewhat distorted and to have some new bone laid down. But mostly it's just eating its way through the marrow spaces in this tumor. So this case was removed prior to the awareness of the effective chemotherapies that we have for Ewing sarcoma now, when surgical treatment was still a little bit more of a mainstay in these patients, although even then not very effective. So those are the teaching points from this: the pattern of growth, the elevation of the periosteum, the interesting use of PAS stain, the cytomorphology of this tumor, and then, of course, the wonderful improvements in outcome with the advent of new therapies. Okay, let's go on to the next case. If you have questions, again, feel free to type them into the comments. So this is an elderly patient who had a joint replacement due to some degenerative symptoms. And as you can see, or maybe even been a fracture. As you can see here at low magnification, there is very pronounced osteopenia. So a very great degree of bone loss with just very few remaining spicules that don't look all that solid. But there's something else here that we don't usually see, and that's, as you can probably surmise here, we have a funny discoloration to the articular cartilage. So we'll leave aside the issue of osteopenia, and here mostly fatty marrow, a little bit of hematopoietic marrow, and focus on this discoloration here. It's kind of a characteristic brown discoloration. It seems to be more intense towards the surface of the joint space, and not even out here a little further past the synovium, we see it. We don't see similar discoloration here in the synovium itself, although maybe you can see here there is a little bit of pigmentation there. It's not well into focus there. But there in the borders of the tissue, you see some of that change. And it's not altogether uniform everywhere, but certainly very pronounced. So what can cause this kind of discoloration in an older adult patient who's undergoing joint replacement? Well, as you may have surmised from my interest in Gaucher's disease, I do have some interest in various metabolic disorders. And this is an example of another metabolic disorder. In this case, a patient with Alkaptonuria or ochronosis. And ochronosis, Ochranosis, is the term for the pigmentation, the dark pigmentation, the ochre-like dark color pigmentation that can occur in various organs in these patients who have a metabolic defect in the metabolism of the mercaptopurines that results in an abnormal pigmentation that can be deposited in the heart, in the liver, in other organs as well, sometimes in the skin, giving them a very bronzed or dark appearance. We don't usually see this in the bone because we don't do joint replacements on these patients very often. They can have a relatively normal lifespan, as you would surmise here from someone who's lived long enough to develop severe osteopenia and have a femoral fracture. But they usually today are better recognized and can be managed with special diets to minimize the impact of the pigment deposition on their bones and joints, skin, and other organs. So again, a very unusual example of a disorder you may or may not ever encounter in your experience. But when you do, think of metabolic diseases that can cause hyperpigmentation. I'm not aware of really anything else that quite gives you this discoloration of the articular cartilage. And as to why it's the articular cartilage, I think it may be some of the affinity with the chondroid ground substances and the metabolic byproduct. Now, many times these patients have an abnormality that is detected because when they urinate, the urine will contain these compounds, and upon exposure to the air, the urine changes color, becomes more dark and discolored as the purines are oxidized and become more pigment avid, or they refract the light differently. So that's how it's usually detected, is through urinalysis, and usually would be at a fairly early age, and so therefore could be managed appropriately. Okay, well, let's delve a little bit further. We've just got a couple of minutes later. This is, again, one of those cases where I look at it and I go, I'm not sure we would make the same diagnosis today. This was a right atrial tumor in, I believe, a 90-year-old patient, or maybe it was an 80-year-old patient, an elderly patient, and obviously not compatible with life to have a mass lesion in your right atrium that's obstructing flow. We can see there's some heterogeneity here. We've got some paler tissue here, maybe some bony tissue here. And then we have this very cellular and somewhat vascularized tissue as well. So at the time, this was interpreted as being an angiosarcoma. That's here you can see very epithelioid, large cells, prominent nucleoli, maybe some degree of vascularity, but certainly angiosarcoma can have large sheet-like areas akin to this. And there was a lot of fibrin deposition here along with it as well. The things that were a little bit odd to me as I looked at this recently were the presence of these cartilaginous areas. an angiosarcoma with heterologous elements. That will seem a little bit odd. And this is not benign cartilage. This is somewhat neoplastic cartilage. It's higher in cellularity. Now, the bony tissue here does not look per se like osteosarcoma because we don't have a high degree of atypia in the bone itself. So this may be reactive bone associated with the cartilage tissue. As you can see here, it's kind of at the periphery of these cartilaginous zones, and it doesn't have the high cellularity tissue. Now, in more recent times, we have been able to determine or to define certain neoplasms in the heart of the sarcomatous type as intimal sarcomas. Those are tumors where you get a reduplication and proliferation abnormal of the endocardial intimal cells. And we might have some of that going on here. More recently, these tumors have been identified to have an MDM2 mutation, which, as you may know, has an interesting correlate with intraosseous type low-grade osteosarcomas. So it's possible that this is the same metabolic driver mutation, and that may be part of what's driving this kind of low-grade chondroid or osteochondroid proliferation over here. I don't know that angiosarcoma is particularly excluded in this situation, but in today's world, I think we would want to see more clear-cut evidence that these cells do express vascular markers before we would accept that diagnosis. So this was an interesting kind of discovery to review this quite unusual sarcomatous neoplasm involving the right atrium. Malignancies in the heart are not very common, especially not primary malignancies, and typically have fallen into this category of being called angiosarcoma. But intimal sarcomas and other types of sarcomas may be ferreted out of that group of neoplasms as we begin to apply more of the 21st century diagnostic tools that we have to work on these. Okay, let's go on to the next case. This is a more recent case, and this was a patient who was thought to have been followed for cirrhosis. And that's the history that came to me, a liver biopsy, patient with cirrhosis. Well, I didn't see any normal liver tissue here, but in fact saw only this very vascularized pattern tissue, a lot of vacuolated spaces or endothelial type spaces, a lot of red cells in the background. Looks very hemangiomatous. Not a high degree of atypia, although we did do a Ki-67 stain and had a not inconsequential proliferation rate in this tissue. So I began to think about various angiomatous lesions that can occur in the liver, hemangioendothelioma or epithelioid hemangioendothelioma came to mind. And so we did some further testing. And indeed, here, as you can see with the CD31 stain, we do have quite a lot of staining, quite a lot of small vessels. It's not staining much of the cytoplasm, but there's clearly an abnormal vasculature component to this lesion. That's not the usual pattern for that. And then we did a further immunohistochemical stain for TFE3, and indeed this was positive, as you can see here. So this is a TFE3 related hemangioendothelioma, and that nicely supported the diagnosis for us, as there is, in this case, a fusion gene involving the TFE3 gene that is associated with this neoplasm, which we termed an epithelioid hemangioendothelioma. Epithelial markers were very weak, only in this case. And so not something that would be particularly helpful. But with gene-specific immunohistochemistries, we can oftentimes do more than we could at an earlier age. Okay, last case, just for fun, a little bladder biopsy. And I know I don't usually do bladder cases, but I like this case because it's very interesting. You can see you've got the normal urothelium, and then you have this process in the submucosal tissues. And this sort of ties back to our earlier cases with Gaucher's disease. You can see there's very kind of histiocytoid appearance here to many of these cells, but it's a little bit busier. The cytoplasm is kind of very finely vacuolated and so forth. But as you look around here, indeed, you begin to see there are a few slightly basophilic rounded nodules in some of the cytoplasm here that are the diagnostic feature for this entity. This is a nice little example of Malakoplakia. And that's one of my favorite little diagnostic lesions. We don't just see it in the urogenital tract. We can see it in other locations. It can be seen rarely in the GI tract, occasionally in the GYN tract as well, but certainly most frequent in the urothelial tract, but also occasionally up in the upper GU tract in the kidney as well. Okay, well, we've come to the end of the cases that I had planned to share. And so we'll stop with that and see if anyone has any questions to bring to the group or any comments on these. If you enjoyed this, I'll continue to do some of these from time to time, going through these archived teaching cases that I've accumulated over my career. I apologize for some of our technical difficulties. I thought I'd run through those and verified that everything was going to work right, but we did have a little bit of a technical difficulty. I want to just announce that next month we'll have a guest professor. It will be Dr. Joelle Peterson, who's a neuropathologist, and she's going to be sharing some of her classic core neurologic lesions that you need to be aware of to pass your boards if you're a US-based person, and to practice in any sort of general setting where there's neuropathology if you're practicing outside the US. So please join us November 22nd. That's actually the fourth Friday of November as we do some CNS lesions with Dr. Joelle Peterson. So I'm not seeing any questions or comments from anyone. I hope you haven't put you to sleep too much. But until next time, we look forward to having you join us again. And please tell your colleagues and friends about our program. We're always open to suggestions and input from our audience.
Thank you.